Abdullah, Fawaz, all the organizing committee, thank you very much for a fantastic program and a fantastic meeting. This is coming here is always a pleasure. And my task today is to talk about the management of coronary perforation. I don't know what's the update, but it's more or less the same. And we're all here experienced in terms of performing angioplasty. So these are my conflict of interest. I'm going to talk to you about the definition, the incidence, mechanisms, and the classification and management. This is probably, if we go through quickly, I will still tour through what we do. Hopefully, by the end, we'll have a good idea about how this is managed. This is a complication meeting, so I thought, although all of us experience, but just to re-emphasize the points that because complications can happen to any one of us and every day. And there are multiple factors that lead to this, whether it's the patient, the equipment, the environment, the institution, but most importantly, it's the operator. And often, if you look back, whatever happened, it's something we've done when we cut a corner. Probably 90% of the time, it's us. Because you think it's going to be okay. You do something you shouldn't be doing because you get away with it, and you end up with complication. So really, prevention is quite important. To be meticulous and careful of what you do, to be prepared and have a plan. You need to know your patient, your equipment, and no cutting corner, because every time you cut corner, and I always say this to the junior, you close your eyes and cross the road 10 times, nothing happens. On the 11th time, you're going to be hit and hit very hard. But because it's a mechanical thing, you end up kind of cutting corner, you get away with it, you think you should do it, and then you get the problem. And when the complications happen, really you have to own it. Don't be in denial. It happens to all of us. Stay calm and own it. Make sure be the leader in the cath lab and give clear instruction and consider the worst case scenario. And of course, there's no shame in asking for help. There are colleagues around who are very experienced. Ego should come out of the window and you really should ask for help. You have to be always prepared by asking what can go wrong with the case. Do I have the technical expertise? Do I have the strong supportive team? And does my institution have the capability to deal with any complication? And if that's not the case, you don't take the case on. You have to be prepared in terms of equipment, coils, covered stent, anything that's needed to treat your complication. And of course, you always have, when we're doing complex cases, if you have a broad ablation, you're having the high pressure or using non-compliant balloon or orbital atherectomy and so on, make a test before you move your balloon, before you do anything, to make sure you haven't left any or you haven't caused any problems. Now we'll come back to the perforation itself. The definition is that evidence of extravasation from the coronary artery during or following PCI. This is no-brainer, obviously. And of course, it varies in degree. The reported incidence about 0.2 to 0.9. However, there are some CTO registries that give us even up to 8.8% of complication rate, which is quite high. But of course, the CTO is a completely different kettle of fish, and you're using more equipment and more complicated cases. And usually, the perforation are associated with high in-hospital mortality and late MACE, and can lead to tamponade. And tamponade could be really fatal if it's not treated quickly. And the predictor, this is a little bit there's a couple or kind of retrospective analysis that came up with this, but it is intuitive. Calcium in the coronaries, complex lesion, and total occlusion. And of course, the age. There are also some, it was a retrospective study from Manchester, in fact, female gender and hypertension and acute coronary syndrome and heart failure were associated with more perforation. I'm not sure how that comes into the clinical practice, but this is what was reported. Procedure itself, the more devices you use, of course, particularly the debulking devices, the more chances of having complication and perforation. Oversized devices, hydrophilic wire are the commonest reason. 90% of distal wire perforation are because of hydrophilic wire, and cutting balloon. And I put the operator down at the bottom in red because honestly, this is about 90% of the time is what we do and how we do it, despite all the other factors I mentioned before. And the classification can be in 3 different ways. You could do it in, first of all, based on the location, whether it's proximal vessel, distal vessel, or collaterals. And also, this is kind of the morphologic. And we've all heard about the Ellis classification from grade 1 to 3, with the 3 cavity into the cavity. And I won't go into too much details because you all know this. If you look again at the classification, if you look at whether it's proximal, mid-vessel, or distal vessel, into the pericardium, or well, what about the pericardium? Because both bypass operations sometimes can be really a very, very difficult situation to treat. Despite, because the pericardium usually is stripped and you have pockets of the pericardium. And if you bleed into one of these, particularly in the area you cannot reach by the pericardiocentesis, that can be really very difficult to treat. And of course, whether you still have a wire in or the wire is out. So management step, which is the most important thing that you need to know about, the first thing you need to do, there's a hole, you need to stop the oozing from the hole. The balloon inflation is the most important. This takes me back to what I said about before. If you go to high pressure with your balloon or use orbital atherectomy or rotablation, before you move your balloon, take a little test, make sure that there's nothing that you have caused any problem. Because often, if you haven't tested, you take the balloon, you're working slowly, talking to everybody. By the time you turn around to take a test, a lot of extravasation has happened. So before you move your balloon, take a little test, make sure there's no problem, and then you could remove the balloon. Or if there's a problem, you inflate it so you don't cause much. And of course, there's covered stent. And sometimes even normal stent could seal a perforation, depending on what you're dealing with. We have coils, thrombectomy, fat embolism, and of course, the first thing to do is to looking at the hemodynamics. If there's any compromise or any pericardial effusion, pericardiocentesis become important. Quite often, the first thing you hear when you ask people when you have a perforation what to do, they say reverse heparin. That's absolutely, it should not be the case. You have a mechanical problem, you have a hole that you need to stop. Reversing the heparin is not going to do anything. And in fact, it may be detrimental. There are a couple series up to 130 patients where 29% ended up with thrombosis. So you really do not reverse the heparin until you treated everything and you removed your equipment. What you need to do is you block the artery with the balloon, you treat it, whatever, we'll come to that in a minute, and then you could reverse the heparin at the end. Rarely, I think 15, 20 years of practice, we probably send 1 or 2 patients to the surgery, but you could always treat them without any issue. So if we kind of summarize it, the first thing, the principle is to immediately block the artery and then reassess. Once you stop the bleeding, then you have a time to think and you have to, and we just heard that about think fast and think slow. The teaching from we say always, don't rush, we're in a hurry. You have to be in control and think about what you need to do. You rush, you can run into trouble. Take a breath and make sure that you're in control. Once you stop the bleeding by blocking the artery with the balloon, you have time to think. Of course, ischemia might come into play in here. We used to have the perfusion balloon, and I think it's coming back on the market because now it's come back in the USA, and it will be coming back where you block it, but there's still perfusion through the central one. And of course, once you've done that, echo can help you if there's a pericardiocentesis. Often in these cases, you could look at the angiogram itself. If you're using contrast, you'll see the contrast in the pericardium, so you could tell you if there's any tamponade or not. If there's persistent extravasation, of course, you have to go, as we see on the right here, you treat the cause, whether it's distal vessel perforation, proximal, and so on. Proximal one will require covered stent, distal one might not, and will require coiling and so on. And rarely you might need to call the surgeon in. So balloon tamponade, covered stents, they are difficult and bulky. Although now with the current 2 stents, which we have, the Papyrus and the Bentley, they are really thin and they could fit even 5 French and more deliverable. And then you both dilate them, which is quite important. And here there are some, just kind of some pictures of them. The Graft Master, I don't know if it's still available. We haven't used it for a long time. It is quite bulky and double layer metal and very, as you can see there on the right side. Papyrus are thin struts and compatible with 5 French. The same with the B Graft. The way you deliver the equipment could be varied, and again, some diagram here on the right. You want to keep the balloon up as much as you can. You could do the bing bong. We take a second guiding catheter. Particularly if you're doing a case with a 6 French, delivering other equipment could be very difficult. So you take a second access, you put a second guiding catheter, and bing bong technique. When you engage with the second guiding catheter, you deliver your wire close to the balloon, you deflate the balloon, deliver it again and inflate. So you keep the balloon inflated until you are delivering equipment. And then you could treat that very easily. 6 French, you could deliver particularly the Papyrus, you could have up to 3 millimeter covered stent can be delivered with the balloon up in the 6 French. Anything bigger, you cannot deliver it. Covered stent delivery, as we said, the bing bong here, just a depiction of this. You could easily do it with two guiding catheter, or a single guide if it is sized and big size. Guide wire perforation is important to understand that could present up to 8 hours after it happened. And quite often, this is why important to monitor the patient if you see any extravasation with the wire. Often they will seal on their own. However, the pericardial tamponade and collection could happen up to 8 hours. And how do you treat these? You could block the artery of the microcoils or polyvinyl alcohol foam, thrombin, collagen. People use fat and also some other, and I'll show you a case with balloon remnant, and occasionally cover the stent across the origin of any branches that you cause the perforation in. And the coils, again, this is just to say tomorrow we'll be doing a workshop about using coils. There was a recent survey that we published recently. 64% of interventional cardiologists have not used any coils, which is very important because it's, you should not be doing this until you're able to use the coils. Of course, there are ways of dealing with this, but so yes, maybe tomorrow with the workshop we could learn all together about using coils. But coils are important to treat distal vessel perforation, and there's a range of coils, different one, whether pushable or detachable, range of sizes. Collateral perforation, particularly now the CTO is very common, are really the most difficult ones because they cause rapid tamponade. They don't have the same structure as the normal coronaries and require bilateral approach. You end up coiling the artery from the donor artery and from the receiving artery. And balloon occlusion try to identify the feeding branch because with the collaterals, often there's like a mesh of these, so you could continue to bleed from different small branches if you don't identify which one it is. Often, if this happens with the collaterals, particularly the epicardial one, you have a microcatheter in, and one way of to maintain or stop the leaking, you connect it to the end deflator. You put the end deflator on negative pressure with the microcatheter, and that sucks. With the negative pressure, the collateral could collapse and allow you to finish your procedure, then deal with the perforation itself. This is a case I did spend 2 hours opening the circumflex retrogradely, but because of removing the microcatheter to protect the artery, you could see in this one here, there was a big loop and the artery is contracting. And when I finished the artery and took a test, there was a perforation because that little collateral has perforated with the artery being twisted with the wire, not protected with the microcatheter. And I ended up having to go coil the artery, the circumflex distally after I opened it and coil the collateral from the diagonal. Something you would like not to do, but it can happen and you have to be prepared to deal with it. So again, just to emphasize the point, and if anything you could remember, take message for me from here, please do not reverse the heparin. If a perforation happens, it's a mechanical problem, deal with it. Do not reverse the heparin until you have dealt with the complication, the perforation, whether you coiled it or blocked it or put a covered stent. Then you could reverse the heparin. Again, this is really important. Do not reverse the heparin until the end. And of course, we always use heparin. You could use the different things to reverse it, but often we could use protamine, which is based on how much you're given, and the dose is usually 50 milligram maximum. So again, to just summarize quickly to say, there are general principles. You see that you identify the perforation, inflate the balloon so you stop the leakage out of the artery. Then you could have time to deal with it and identify where the perforation is, what you are going to do with it, and how you're going to do it. But again, do not reverse the heparin. And if, in rare occasions, things are not settling down, surgery may be required. But for a long, long time, this hasn't happened. So really, prompt diagnosis and immediate balloon inflation is important. Pericardiocentesis if there's any hemodynamic compromise. And subsequent management is tailored to what you see according to the type of perforation. You have to have your perforation kit ready and consider reversing the heparin at the end after you build all your gear. And every coronary perforation, of course, has a different behavior and prognosis according to the clinical status and according to the anatomical setting. So be prepared, meticulous, and careful. Oh. Sorry, okay. Just to be also prepared and know exactly your equipment and your case, and be prepared to dealing with all this, and allow the patient to have a very good outcome. Thank you very much.
Thank you very much.